story begins more than 60 years ago inside an abandoned chicken coop where our founder discovered a retired teacher living, no home, no health care. So she said no to this injustice and yes to transforming lives. It's this drive, this compassion that inspired AARP. Today, we empower people to choose how they live as they age. We advocate for health and financial security. We strengthen communities everywhere. We are AARP Georgia, creating real possibilities.
One way to kind of be familiar with what we need to be familiar with is to be constantly learning about a lot of walks of life, particularly about health. So quite often we try to have individuals from the medical community to come and educate us on health and on diagnosis and treatment and prevention and a lot of things, and the kinds of diseases and a lot of things as it relates to health. And we have not had anyone before who really was a specialist in pancreatic cancer. And of course, all of us are familiar with cancer and, you know, the plight that people go through who have it. But we're not that familiar with pancreatic cancer, although I understand it's a pretty serious type of cancer. So we are more than a little fortunate today to have with us Miss Dr. Roxana Coman, you know, who's a GI. And when she told me she's a GI, you know, and I was trying to ask for the proper initials behind her name since she is a MD, and she said GI. And I, of course, told her, we can't use that. Now, they're going to think you in the army. But a GI is a gastroenterologist, which she is, and there's something distinctive about her being a gastroenterologist and a female and things of that nature. So we want to just talk about not only pancreatic cancer, but her specialty is gastroenterologist, urology, which, you know, deals with the stomach and related parts. So we're just so happy to have you. How you doing?
I'm doing just fine, thank you. And thank you for inviting me here.
Yeah. How did I do with the Roxana? I mean,
great.
We had some fun. You know, I told her that, you know, the brothers and sisters call it Roxana, but she's from
I'm from Romania.
Romania, so it's different. So tell us a little bit about yourself.
So, to make a long story short, it spans 2 continents. I was born and raised in Romania. It is where also I graduated from medical school. So, at that time in my medical school, Romania was in a period of transition. It was right after the fall of the communism regime there, and an unfortunate event happened at that time. We had an epidemic of HIV and hepatitis due to contaminated medical supplies and blood products. So the population mostly affected were children, and I took care of a lot of those children in medical school, and that sparked an interest in learning more about these diseases. So I applied to a research program in the United States at University of Florida in Gainesville, Florida. And I was accepted there. I graduated in 4 years with a PhD in biomedical science.
Wait a minute. So you got a PhD and an MD. So you didn't tell me that. Okay.
Just give a little bit of surprise.
A PhD in what now?
In biomedical sciences,
okay.
And mostly drug design, molecular modeling, and crystallography. So that was a very interesting period in my life where I learned a lot about physiopathology of the disease. But my calling was always clinical medicine. So my husband was pursuing his studies in the United States at that time as well.
He was what?
Was pursuing his studies. He's a physician as well.
Okay.
So we were together doing research at the University of Florida, and we decided we would like to pursue our medical studies here in the United States. So this is how I did internal medicine residency for 3 years there at the University of Florida, and I followed with a fellowship on gastroenterology and hepatology. And because I haven't had enough years of studying behind me, I decided to do an extra year of advanced endoscopy, also at the University of Florida. Advanced endoscopy, just learn a little bit more about the gastroenterology, and you acquire more a technique in doing endoscopy, which is fun for me. I always
Now,
enjoy
endoscopy, explain that.
Endoscopy, you do it's a colonoscopy and upper endoscopy. It's you use an endoscope, which is a thin tube with a light at the end and it is connected with a camera. So you have one in the left hand. You have the dials, and you kind of direct where the tube will go. And with the right hand, you just control the tube, and you look at the screen, and you introduce the tube through the mouth in the throat of the patient.
So the
and
endoscopy
goes through the
goes
food
through the
pipe,
mouth.
yes, through the food pipe and in the stomach, and you look and see if they have any abnormal that might explain their symptoms, an ulcer, a lesion, a mass, a cancer. So you can diagnose it this way. So it's a real-time procedure, and you can take biopsies or tissue samples and put a diagnosis. Sometimes patients come with bleeding, and using that tube, you can actually stop the bleeding.
Wow. Now, with an endoscopy, can you get into the intestinal areas?
Yes.
Or do you have to have? Now, does an endoscopy replace a colonoscopy?
So, and usually when we refer to endoscopy is more of a general term of using an endoscope. So you can do an upper endoscopy, which is through the mouth, or you can do a colonoscopy, which is through the bottom. And this is when you look at the colon and you screen, somebody comes with rectal bleeding from his bottom, you look and see if they have an ulcer or a mass, or if they have diverticular disease, which is out pouches in the colon that can bleed. So we can do this, we can go that way from below as well. The intestine.
But they're not interchangeable. I mean, they're not.
No.
They don't both do. No, they don't both do the same thing.
We use different scopes.
Okay, for
the upper,
this
use
way,
a thinner scope, and from the
and you can't do an endoscopy and go all the way through the large intestine, small intestine.
No. You have about 10 and more feet of small bowel in between, so we do not have an endoscope that long. That's for sure.
That's pretty good.
But we can do endoscopy, and we can look at the small bowel. It's just a specialized type of endoscope, and that's why you need advanced training. It is what I did the extra year. In addition to 3 years of general GI, I did an advanced year, because we used to learn these devices, like a long balloon over the scope, or you can go really deep in the small bowel, or you can look in the liver, or you can access the pancreas.
Oh.
So not all general GIs can do this procedure. There is a small percentage, maybe 10 to 15% of them, that get this specialized training.
Now that's advanced training.
Yes.
The endoscopic, I'm calling it a word.
Therapeutic endoscopy.
Yeah, the training is kind of advanced. So let's enumerate them. So you're an MD.
Yes.
You're a GI. Now, what is the endoscopy expert called?
It's just advanced therapeutic endoscopist.
Advanced therapeutic endoscopy.
Mm-hmm.
Oh,
Yes.
very good. Now, when we first started talking about finding someone to be on the show, they mentioned that your specialty, one of them is in pancreatic cancer. But before we talk about that, let's talk about, stomach and intestinal health and polyps and what people need to do, because I've had 2 members of my family to die from colon cancer. And I know it's fairly serious, but very serious. But, according to some reports, it's avoidable. I mean, death is anyway.
Yes. Yes.
So talk a little bit about both the endoscopy elements of what you kind of look for, and the colonoscopy, if you please, elements of what you kind of look for.
So with upper endoscopy, this is mostly a diagnostic procedure. We don't do it routinely unless the patient complains of either heartburns, or they have abdominal pain, or they have constant nausea or vomiting that makes us think they maybe have an ulcer or something else going on. So then when the patient is referred to a gastroenterologist from his primary care doctor saying, oh, doctor, I had this, it really bothers me, then there can be many things, but can also be ulcers. So then we do an endoscopy. When you talk about polyps, I think you're referring to polyps that grow in the colon and then further develop into cancer.
Right.
And this is why there are now guidelines that recommend screening colonoscopy. Polyps are very unusual in younger people, but once you go in advancing age, about 50, it's the cutoff. People tend to develop polyps. So it's just an affliction of older people. And because there is at least 10% of population develops polyps, it is very cost efficient and health efficient to recommend screening colonoscopy. What it means that everybody who is older than 50 years of age are recommended to have a colonoscopy regardless if they have symptoms or not. So you do not need to have abdominal pain, you do not have to have bleeding, you do not have to have any symptoms, you just have to be 50 years or older to have a colonoscopy. And now in certain population, this is recommended even earlier. If you had family history of colon cancer, like a first degree relative, parents or siblings, they had colon cancer, you should have colonoscopy earlier, at least 10 years earlier from when your relative had cancer, if they were younger than 60 years of age at the time of the diagnosis. So don't wait to have symptoms. Go talk to your primary care doctors. All primary care doctors know these guidelines. Everybody should have a colonoscopy once they turn 50 years of age, or even earlier if there are some circumstances in their families.
And then a lot of people, there's all kind of comedic, shows and stuff like that about, people like to make fun of it. But it does not hurt and it does not dangerous, right? And just talk about the process.
The process.
Because there's a lot of people out there, and like I had family members and I'm sure that both of them could have lived with earlier detection, and for whatever reason, it breaks my heart. So talk about, the process and whether it's painful and how long it takes and what's necessary.
Yes, it will be my pleasure to clarify this, because in this way, if people can understand that it is really a routine procedure for us at this point, they will be more willing to follow the recommendation. So usually, I'm employed by Navicent, and they have outreach programs that they offer colonoscopies, even for patients who do not have primary care doctors. But routinely, you go to your primary care doctor, they refer you to a gastroenterologist, and they will recommend a colonoscopy, which usually is done in an outpatient setting. So it's a very simple procedure. The patient needs to prep their colon before the procedure, and this is actually the hardest part. That they will be sent a prescription where they go to pharmacy and they get maybe half a gallon of a laxative.
Yep.
Yes. And then usually they should have a lighter diet 2-3 days before the procedure, maybe just liquid diet the day before the procedure.
Been there, done that.
that is the hardest part. Not when you smell steak, that your family members eat and you just have to stick with Jell-O or things like this, but it's worthwhile. And then the night before, they have to drink the laxative. Might keep them all night awake because they have to use the bathroom, but again, this is the worst part of the procedure. The next morning, you go to the outpatient center and have a colonoscopy. There is an anesthesiologist there most of the time that assesses your health situation and makes sure that being put to sleep is safe. And then they will have an IV, and they will give you medication to make you comfortable and sleep during the procedure. So you'll be comfortable, you'll not know really what's going on. While you are asleep, the endoscopist will do the procedure, and again uses the endoscope with a camera at the end and goes from the bottom all the way, which you call the anus, all the way to the cecum, and looks very carefully to the walls of the colon, make sure there are no polyps. If we see polyps, we remove them. And polyps can come in different sizes. Smaller sizes are obviously easier to remove. Larger size polyps, they have some additional risk associated with removal, and it depends on the skill of the endoscopist if they will try to take it out at that time, or just have send them to an advanced endoscopist or a surgeon. But the larger polyps are the ones that carry the most risk of cancer. So the procedure, it's an invasive, it's a minimally invasive procedure, but we do put a foreign object in your body. So potential complications are bleeding, perforation, infection. Very rarely happens, 1 in 500 procedures or less. So really the risk is minimal for the health benefit that this has long term. So then, if no polyps were found and the preparation of the colons were excellent, next colonoscopy is in 10 years per recommendations. If polyps were found, depending on how many and the size, you will need to have repeat colonoscopies in 3 to 5 years.
Now, sometimes one can have, usually if the polyp is cancerous, it'll be a bit larger, right?
In general, yes.
Yeah.
In general.
But sometimes you can have a larger polyp and it not be cancerous?
Yes, you can have. I've seen quite large polyps, meaning like an inch size, that they don't have cancer
like
inside.
What?
An inch in size?
Inch.
Like inch.
1 inch.
1 inch, yes. Or even larger. That sometimes we can remove with the endoscope and the patient doesn't need to have surgery. But that is practically a ticking bomb. That polyp can grow into cancer anytime. Now there are different types.
Now, if there's a larger one,
the risk for cancer
it's more precancerous, if you please.
Yes.
So the suggestion is to remove it?
Yes, all polyps that we see we usually remove. There are 2 major types of polyps. Precancerous, that are not really cancers, but they grow into cancers, and these are the most common ones you find in the colon. And there are polyps that are benign, like hyperplastic polyps. Those very rarely grow into cancer, but again, at larger sizes, even those need to be removed because there is always a risk.
Okay, now I've seen some advertising about this home test for, it's supposed to be an alternative to a colonoscopy where
Yes.
you can send a stool sample to some company or what have you.
That's correct.
How reliable are those?
So
Now, what do they design? Excuse me for cutting you off.
Absolutely.
To detect blood in the stool?
Blood in the stool, or sometimes pieces of DNA.
Pieces of what?
DNA from the polyp. But most of the time, blood. There have been older tests, and newer tests are more sensitive and more specific. Some are covered, some insurance cover those tests, some they don't. So this is where some of the differences in if they are still accepted or not. But patients who are where their health doesn't permit to have colonoscopies every year, those are tests that can be used at home, as long as the patient does it regularly every year. And then if they return positive, then we'll have to discuss it.
So it's possible?
Yes, and
It is
many
possible
people
to detect it from those stool
samples.
tests? Oh, okay.
Yes.
That's very good to know, because I know I have seen it advertised. So how many women, you're the first woman gastroenterologist that I've seen. So are there many females in this field?
So let me think of some numbers. I think in 2019, based on the articles I read recently, maybe 15,000 gastroenterologists are in the United States, and I think about 20 to 30% are women. And this is actually an improvement from several years ago, when less than 15% were women in gastroenterology. Now in advanced gastroenterology field, there are even fewer, maybe less than 15%, based on most current statistics.
So now you're being trained and certified in advanced endoscopy and colonoscopy makes you advanced.
So what makes me advanced is that general GI, when you finish 3 years of fellowship, you are trained in doing the upper endoscopies and colonoscopies. Advanced training is an extra year, and it teaches you to do specific procedures like EUS, which is endoscopic ultrasound, and among other procedures, an ERCP, which the full name is retrograde endoscopic retrograde cholangiopancreatography. So we'll stick with the RCP. Is it actually where you can explore the bile ducts inside the liver and remove stones or infections on people like that.
Okay, now so is the liver attached to gastroenterology training?
So the fellowship is gastroenterology and hepatology. So you learn about liver, and patients who come with abnormal liver numbers to the hospital, they will be treated by a gastroenterologist. All these physicians work together, like gastroenterologists work together with surgeons and oncologists. But the main doctor who will be called for a consult or the primary care will send somebody with liver problems is a gastroenterologist, yes.
Oh, wow. Well, that's good to know. Okay, so now how does the pancreas tie into this? I understand, excuse me, I understand that this is a call to action.
A call to action.
I'm your host, Alex Havisham, having this, I can't pronounce her name, I can't pronounce mine.
Roxana Coman.
Having this very, very interesting conversation with Dr. Coman.
Yes.
Who's a GI, technically known as a gastroenterologist, and we're just enjoying this conversation. And we're going to move into the element that we really had agreed to talk about, and that's pancreatic. Talk about what the pancreas does, and not only its function, but how does cancer enter into it. And I think it's really serious as opposed to some other forms of cancer when a person has pancreatic cancer.
It is. So a little bit of background on pancreas. Pancreas is an important organ, sometimes overlooked organ in the body.
Because you don't hear much about it.
Yes.
You really don't.
That's true. And it actually lies behind the stomach in the abdominal cavity.
Okay.
And it's between the spine and the stomach. And it has several important functions. One is digestion. It makes enzymes that helps digesting fats, proteins, and sugars. And those are broken down in small pieces that they get absorbed by the intestines. Somebody with pancreatic insufficiency, if the pancreas doesn't work well, then they will develop a lot of diarrhea because some of that foods, especially lipids, are not digested. So it is important that when the patient becomes malnourished, because they really cannot absorb essential nutrients for the body. Another important function of pancreas is for blood sugar levels. It secretes hormones. One of them is insulin that helps controlling blood sugar levels. Patients who have diabetes, sometimes they have problems with the pancreas. So these are only two of the important
So the pancreas is also tied to diabetes too?
Yes, it is. Diabetes has a very complicated physiopathology, but pancreas dysfunction is one of them. So pancreatic cancer, when we refer to pancreatic cancer, it's mostly what we call the exocrine part of the pancreas, the part that helps with digestion. And about 90 to 95% of the cancers are developed in that part of the pancreas. It is as prevalence about top 10 in most prevalent cancers in the United States. So it's on 10th place in males and 9th place in females. But it is the 4th leading cause of cancer-related death in the United States. So what it means that at the individual level, while other cancers like breast cancer, colon cancer, prostate cancer are more prevalent, pancreatic cancer is deadlier. So to put it in a different way, one of the measures to look at survival rates of patients with a certain cancer after diagnosis and treatment is a 5-year survival rate, meaning the percentage of patients that are still alive in 5 years after diagnosis. So
with pancreatic cancer.
so let me give you an example. For prostate cancer, the 5-year survival rate is 98%,
Wow.
almost. So almost all patients with prostate cancer are alive 5 years after diagnosis. For breast cancer, it's about 90%. 90% of the women are alive 5 years after diagnosis. Colon cancer, 60 to 70%. Pancreatic cancer, all stages altogether, 9%. 9%. If the
5 years later, only
5 years, only 9 out of
9%
100
is still living.
is still living. If the cancer is detected at an earlier stage, hence the importance of what we are going to talk later, the survival rate is 20 to 30%.
Wow, that's still serious. Though.
That is a serious difference. If the cancer is diagnosed at a later stage, when there is a lot of local growth or spread to other organs, survival rate is 2%. So that was the importance of prevention and early detection.
Okay, well, let's talk about that before we give out of time.
Okay.
Let's talk about prevention and early detection.
So there are a few, several factors that have been associated with increase in risk of pancreatic cancer. Hereditary causes about 10 to 15%. Patients who have certain syndromes in their family, patients who they have family members with colon cancer or breast cancers, they have a higher. There are several syndromes that are associated with high risk of pancreatic cancer. Certain mutations are associated with risk of pancreatic cancer. Chronic pancreatitis is another disease that is associated with chronic pancreatitis,
Okay.
like chronic inflammation in the
Okay,
pancreas,
yeah.
is associated with increased risk of pancreatic cancer. Environmental factors, smoking, very important, increases the risk of pancreatic cancer 2 to 3 times over the level of non-smokers at the same compared ages. Just to give you an example, in patients who are more prone to develop pancreatic cancer, as in families with pancreatic cancer, smokers develop cancer 10 to 20 years earlier than non-smokers. Obesity, some studies show that people who have BMI of higher than 30 have a high risk of developing pancreatic cancer than people who have BMI lower than 23. There is no proven link with diet, but unhealthy dietary habits lead to obesity, so obesity increases risk of pancreatic cancer.
Right.
The same with alcohol, not really proven link, but long alcohol use can cause chronic pancreatitis, and chronic pancreatitis has been associated with pancreatic cancer. So there are many environmental and personal factors that we can modify to decrease the personal risk for developing pancreatic cancer.
It can't be cured.
Cure, it's can have different significance in cancers, but early cancer you can live many years. With after surgery and with chemotherapy you can have.
Can you cut it? Can you operate on the pancreas?
Yes, that's another important factor why early detection it's important, because smaller cancers can be removed surgically, which obviously increases the risk of survival. Increases the risk of the chance of survival.
Right. Now, quickly, is there a test that can determine, like a blood test or something like that, which will indicate that you may have pancreatic cancer? Well, how do you find out if you got it, Doc?
So, okay, that is a very good question. And again, it's a very elusive disease in the sense that it doesn't really have specific symptoms. People can present with nausea, some epigastric discomfort, weight loss, generalized fatigue. So when people start having these symptoms and they don't go away despite a healthy lifestyle, they have to talk to their primary care doctor. Some other symptoms like pain that goes in the back is more specific for pancreas. Yellowness, where you have yellowness of the skin or of the eyes, it's called jaundice, and it can be due to the pancreatic cancer growing and obstructing the bile flow. That is also a relatively important sign, but sometimes can be seen late in the disease progression. So by the time the patients come to us, there's already pretty advanced cancer.
Well, we're just about to run out of time, unfortunately, and I am so.
Well, I'll be very happy to come back and continue.
Yeah, I'll be
This
very
was
happy for you to
interesting.
come back because I think we're going to have to do phase 2 on this one. And I'm serious because it's so important to the community and there's so little knowledge about it. So I really, really appreciate your comment. Welcome to Georgia. Congratulations on all your degrees.
Thank you. It's
And
a
all of
pleasure to
that,
be
and
here.
all of that. And I'm just in awe at your knowledge and your interest in trying to help the community and educate the community on different kinds of cancers and other diseases related to gastroenterology. So thank you so much.
Thank
for
you
your
very much for
appearance.
having me.
Yeah. This is a call to action.
A call to action.
I'm your host, Alex Havisham. Have a great day.
Thank you.